Good evening, everyone, and welcome to the EUROGEN webinar series. As you can see, we're fully into the Christmas spirit. So just before we get started, I'd like to take a couple of minutes to explain a little bit about what EUROGEN is and does. EUROGEN is one of 24 European reference networks created and funded by the European Commission since 2017, and they all deal with patients with rare diseases. And EUROGEN specialises in patients with rare urogenital diseases and complex conditions. And we're now a network of 56 healthcare providers in 20 member states, all collaborating together. So what do we do? Well, our aim is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urogenital diseases and complex conditions who all need highly specialised surgery where the expertise is rare. And I hope you noticed from the slides at the beginning, one of the innovative services that we offer is cross-border virtual consultations using a highly secure IT system provided to all the ERNs by the European Commission, which allows us to do these virtual consultations in a safe way. Any healthcare professional working in any member state can request the help of the ERN. So please feel free, and I strongly encourage any of you to reach out to us if this would be helpful. We also collaborate on education and training activities, producing clinical guidelines together, and a very exciting new development is we're collaborating on a patient registry. So over 25 years plus, we'll be able to track the clinical outcomes and quality of life status of our patients, which is very exciting. So without further ado, this evening's webinar is one of our colorectal series of webinars, and it's about anorectal malformation dilations after surgery, the pros and cons. And the webinar will be kindly presented by Dr. Eva Amerstorfer from the Department of Paediatric and Adolescent Surgery in the Medical University of Graz, Austria, and Dr. Alejandra Villanova, who's a paediatric surgeon from the Children's Hospital La Paz, Madrid. And the discussion will kindly be moderated by Dr. Eberhard Schmiedeke, who's a paediatric surgeon from Bremen-Mitte in Germany. So thank you very much to our experts for sharing your expertise with us this evening. And I just also want to mention that the webinar is accredited, and it's a joint webinar between ERN EUROGEN, ERNICA, and it's supported by EUPSA and the ARMNet. So over to our experts. Thank you so much for joining us this evening.
Good evening. It is my pleasure and honor as the moderator of this webinar to welcome you to a subject which goes right into the heart of anorectal malformation therapy, namely to achieve fecal continence. Following a hint of the patient organization SOMA, I learned something from the physiotherapists and psychologists in the ARM multidisciplinary follow-up teams in Nijmegen, the Netherlands, and at home in Bremen. Poor sphincter muscles are not the only problem. Next slide, please. Many ARM children simply do not know how to defecate properly. Painful stimuli to the pelvic floor increase their functional problems by causing reflective, fearful contractions of the pelvic floor in attempts to squeeze. The two main causes of pain are ulcerative nappy rashes after colostomy closure and painful dilations of the neoanus. The next slide, please. While collecting data for the German CureNet multi-center study by interviewing parents at their homes, I discovered the tremendous amount of psychosocial suffering afflicted to the families connected to this. So I began to fight against painful dilatations in my clinic and also through publications and on congresses. Yet in the last years, the pendulum swung to the other side, with some colleagues abandoning any postoperative dilatations, which is not necessarily helpful, as we will hear in a minute. Beforehand, let's clearly define two crucial terms. Calibration means to only measure a given caliber, in our case, the diameter of the neoanus, by determining the maximum Hegar size which passes the neoanus without any resistance and without any discomfort to the child. Dilation means to increase a given caliber. In our case, it means stretching of the neoanus with the aim of an on-lasting increase of its diameter. Please let's use these self-explaining terms correctly, not only today. And now let's listen to our speakers, to dedicated experts in the field. Thank you very much.
Well, ladies and gentlemen, I'd like to say welcome to our webinar today. And thank you to Michelle Batty and also to Eberhard for the kind introduction. And I hope we can all give you an overview about dilations which are performed after anorectal malformation surgery. We have no conflict of interest. And before we start with our actual presentation, we'd like to see what is actually your current practice in your hospital. And for that, would like to raise a poll question to the audience. And with the question, do you perform regular postoperative dilations after PSARP or laparoscopic anorectoplasty? Yes, I never perform dilations, or I calibrate the anoplasty and perform dilations only if needed. If possible, please answer.
I'm just going to wait a couple of seconds until more people have voted, and then I will close the poll, and then you can see the results. About 60% of the attendees have voted, and I'm going to close it now.
So the results show that the majority is performing dilations routinely as a postoperative, as according to the postoperative protocol, and some only perform if needed. Well, we know in patients with an anorectal malformation, our goal is to create a neoanus to restore bowel continuity and allow undisturbed defecation. The neoanus is of course created in the center of the sphincter muscle complex by a circumferential anoplasty. And the diameter of the neoanus will be determined by the age of the patient and by the according size of the sphincter muscle complex. We know that Professor Peña, when he introduced the PSARP procedure in 1982, he also introduced the postoperative dilation protocol. And this protocol is nowadays, or since then, traditionally used in most of the hospitals where anorectal malformation patients are treated. According to his protocol, 2 weeks postoperatively, we start with a Hegar dilator around the size of 8 or 9 millimeter, so smaller than the neoanus collimer. And this Hegar dilator is introduced and then weekly progressed, originally by the protocol from Professor Peña, by 1 millimeter until the normal anal size is achieved. Optionally, it's also documented according to literature that a plastic dilator or a parent's finger can be used. But what is actually the normal size of an anus? I have an answer for that. Elharad and Kokri have introduced an equation in 1985 to estimate the caliber according to the body weight. And this equation says that the caliber is calculated by 1.34 multiplied with the patient's body weight plus 6.8. And according to this equation, we come to a size where we obviously see a linear relationship, as you can see in the figure on the right-hand side, between weight and the anal diameter. And according to this equation, the size of the anus is actually slightly a little smaller than the numbers which have been introduced by Professor Peña. And that would mean that a newborn weighing 2.5 kilogram would have a size of Hegar 10, and a newborn weighing 3.5 kilogram would have a size of Hegar 12. So there is a slight difference, which depends on the patient's body weight. So we know that anal stricture is a severe consequence, a severe complication of a PSAP procedure. And to avoid that, a dilation protocol is performed nowadays by more than 80% of pediatric surgeons. So actually, this is more or less reflecting your routine in your hospital. Stricture rates are reported between less than 5 to even up to 78%. However, a stricture is not uniformly defined, and it has been once described as a palpable skin level stenosis on digital exam and measured as a size 10 or less in Higa dilators, according to Elhaddad and Kukri. So factors that influence that the anal stricture develops are inadequate blood supply, excessive tension, technical errors of anastomosis, and a physical injury of anastomosis. According to Professor Peña's group and Andrea Bischoff, strictures can be avoided by a meticulous surgical technique and adherence to a standardized dilation protocol. So this dilation protocol tells us that the Higa dilators are introduced for 30 seconds 2 times twice a day, meaning in the morning and in the evening, and the size is increased by 1 millimeter a week. It's recommended to use water-soluble lubricant to aid passing the dilator and performing dilations before meals. If you have difficulty passing the next size, then take the previous size and then again raise the size again to the next dilator. It's said that same size of the dilator should never be used for more than a week. So what we've just heard from Eberhard Schmiedeke is that the traumatic, painful, forceful dilations must be avoided in every way. And dysfunctional defecation can even occur if trauma has occurred. It can also lead to constipation and overflowing continence, and even a psychosocial burden caused later in life to parents and to patients. So it's one of the paramount paramount goals that dilations should never be performed painful. It's said by, again, Professor Peña and Andrea Bischoff's group that preserving adequate blood supply to the bowel, avoiding an undue tension of the bowel to skin anastomosis, and respecting the limits of the sphincter will actually make regular anal dilations a painless experience with no suffering and only minimal discomfort. So maybe every one of us has already used a finger to dilate the anastomosis, and especially in countries where Higa dilators are not routinely available, like Africa, where we have here on the left-hand side this beautiful picture of a hand where the group from Chumbi in 2019 have investigated a study where they routinely used fingers instead of Higa dilators. And if the compliance is well, then it's a good option. However, we have to be aware that the fingers are not always of the same size of the like compared to Higa dilators, and a little finger more or less resembles a Higa 11 to 12, and in contrast to, of course, a thumb, which is almost Higa 17 to 17. In our hospital, we also use anal dilators, which are made of silicone, like you can see on the picture on the right-hand side. The silicone dilators are flexible and maybe take a little bit away the feeling that it's a rough instrument to insert into a neoanus. And this silicone dilator is available in different sizes up to size Higa 16, so 16 millimeters. We actually have a well compliance by the parents to use them. So looking into the literature, an anal stenosis rate is described as less than 5%, according to 80% of pediatric surgeons who follow a dilation protocol. This result is from an international online survey which maybe has a little bias as it's not evidence-based. It's known from Professor Peña's group, or described, let's say this way described, that postoperative anal strictures can be even avoided by a proper surgical technique and an adherence to a dilation protocol. Now, we've heard that there is a trend, and it's of course parents are reluctant to perform dilations if they're not taught properly, that daily parental calibrations are compared to weekly dilations, which have been performed by staff surgeons by the group from SIG Toronto. And they came to the result that there is no statistically significant difference. But we will hear now from Alejandra that maybe this is only absence of evidence. And according to a recent randomized controlled trial, where different hospitals, where two groups have been compared, where patients were not dilated at all compared to patients who followed routine postoperative dilation protocol, that there also was no statistically significant difference in stricture rates. So does this mean it's time for change? And is it really better not to dilate compared to dilate? And about this will Alejandra now talk you through.
Yes, thank you, Eva. So I'm taking over from now on. As Eva has mentioned, when we do a quick look into the literature, there is contradictory information about the need of performing dilations. For pediatric surgeons, it's very hard to follow recommendations when different centers with great experience propose different management for the same type of patients. Today, I will try to show you the small prints in the available literature, and we will analyze meticulously the most relevant papers to try to offer a more objective view on this topic. First of all, we have to recognize that there are multiple factors that could potentially impact in the need of performing dilations. For example, the surgical technique we use. We shouldn't compare a patient with a retroperineal fistula who underwent a mini PSARP, like the patient in the picture above, with another with a laparoscopic assisted PSARP or a PSARP buff in a cloaca, like the patient in the lower picture. Because these differences imply different dissection approaches and also different type of malformations. Secondly, the size of the anoplasty at the end of PSARP will determine whether the patient will need dilations in the postoperative period. Here, I show you some representative pictures where we observe one anoplasty above, which is excessively large, and a normal one in the lower picture. The probability of needing dilations on patient in the upper picture is much lower compared to the patient in the lower one. So it would be mandatory to mention the size of the anus at the end of the PSARP in every single patient, in every single paper talking about postoperative dilation. The tension of the anoplasty will determine its blood supply and therefore the likelihood of a stricture rate in the postoperative period. The tension could be influenced by the presence of a colostomy and where it was placed, the length of the distal rectum from the mucous fistula visible in the lateral view of the high-pressure distal colostogram, and also the length of the fistula or rectum that was trimmed at the time of the PSARP, as the picture you can see in the lower picture. And last but not least, the personal healing process of each individual. For example, this is a patient after a primary PSARP, and we can see this scar tissue he developed. Before the procedure, we cannot anticipate how the patient is going to heal. So, do you think that literature can consider all these factors objectively? Of course, not, because we cannot measure the tension of the anoplasty and cannot control each individual's healing process. This is one of the reasons we think there is no perfect protocol that works for every single patient. Now we start with the critical analysis of the most relevant literature. This is a paper published by the Sick Kids team in 2012. They analyzed patients with Hirschsprung's disease and anorectal malformations. When we focused on the ARM patients, they have a total number of 61. 48% underwent routine postoperative dilations, and 13 only weekly calibrations at the clinic. They say that they did not find statistically significant differences on the late stenosis rate or redo surgery between these two groups. With regards to these results, they advocate to perform only weekly calibrations in clinic to assess whether they will need routine daily dilations. But when having a deeper look into the data, they had 11% more of stenosis in patients with ARM and non-dilation. And 4%, this is 4% versus 15% in the non-dilation group. I have highlighted that in red. And 4% more of redo surgery in patients not receiving dilations. Even though they say the difference was not statistically significant, I think this is clinically relevant. Professor Janetsky performed a power analysis of this paper, and he found that they will have needed 240 cases in order to find significant statistical difference. With only 61 patients, the difference was not significant, but there was still a difference. On the other hand, we also found some weaknesses. They did not mention the size of the anoplasty at the time of the PSARP and not specified what they consider anal stricture. And they didn't even mention the prolapse rate. Additionally, the anoplasty in both groups were done by different surgeons, which could potentially impact on the way they were done, the tension, and the length of the resected rectum or fistula. This is the second paper we are going to discuss. This is from the UK, from Great Ormond Street and the Liverpool team in 2019. They included 103 ARM patients and divided them into two different groups. In institution A, they followed a protocol with routine postoperative dilations, and in institution B, they only performed calibrations of the neo-anus at clinic or under general anesthesia. They did not find significant differences in the number of dilations under anesthesia or redo procedures between these two groups. However, when reading the results carefully, they mentioned that 78% of patients in the non-dilation group received calibrations under general anesthesia at the time of the colostomy closure, and 83% of them ended up receiving one dilation before the colostomy closure because they developed a small stricture. The rest of patients, 20%, had a mean of 2 dilations from 1 to 6 under general anesthesia before the stomach closure. That means that only one patient did not receive dilation at all during their follow-up. We also find some methodological issues in this paper that could impact on the interpretation of the conclusion. For example, first, they did not mention what Hagar size was considered a stricture. Second, the procedures were performed at different institutions with different surgeons. And third, we wonder if dilating under general anesthesia could lead to overdilate the anoplasty. And lastly, we think there is an extra exposure to general anesthesia in this series. This is the third paper. This is from the Columbus group and was published in 2021. This is the only randomized controlled trial on this subject. They randomized 50 patients, 25 in each arm. They assessed the anoplasty at 3 months after PSARP, and they considered a stricture when the anus was smaller than Hagar size 10. Families were informed of the risk of not doing dilation, and in the case of developing a stricture, they received a Heineke-Mikulicz anoplasty, as the one you can see in the left-hand side picture. This Heineke-Mikulicz anoplasty aimed to enlarge the size of the anus by doing a longitudinal cut and sewing it transversally. This could be done in only one quadrant or in all four as needed. This series found 21% of stricture rate on the dilation group and 32% in the non-dilation group. This is relatively high compared to the incidence reported in the international survey by Giulia Brisigelli. The rate of prolapse was also slightly higher, with 29% and 16% respectively. They did not find differences between groups in terms of rate of stricture, need of Heineke-Mikulicz anoplasty, and need for redo surgery. Although this is the only prospective randomized trial, there are some research questions regarding the long-term follow-up after this Heineke-Mikulicz anoplasty. Does it have some influence on future over-scarring or continence? We don't know that yet. And also, the low number of patients did not allow a subgroups analysis to better understand what subtypes of ARM would be more likely to need dilations in the postoperative period. This is the last paper we are going to analyze. This is from the Colorado group, Dr. Bischoff and Dr. Peña, and it was published last year in 2022. They included 84 patients, and all of them received dilations following their protocol that we have already commented. Eva did it earlier. And none of them developed a stricture, and their rectal prolapse rate was 7%. This is the only reference in the literature reporting 0% of stricture rate. However, we found some methodological issues that could impact on the interpretation of this data. For example, they did not mention the size of the anoplasty at the end of the procedure and for how long the dilations were performed. After this literature review, I move on to present what we have been, the protocol that we have been following at my institution in La Paz in Madrid. We calibrate the anoplasty starting 3 weeks after PSARP and continue the calibrations once a week at the clinic. In my opinion, 2 weeks postoperatively sometimes is too early to manipulate the anoplasty. That's why we start on week 3. We introduce through the anus the Hagar size the patient had intraoperatively. This size usually corresponds with the size they need to have by their age. In case of difficulty or pain passing the Hagar, we stop the calibration and go for a smaller size. In this case, we start what we know as a routine postoperative dilation protocol until the goal Hagar size is reached. Our goal size are slightly smaller than the one proposed by Peña's group, especially in the first months of age. We included 33 patients. with a mean age at the anoplasty of 4 months and a mean of Hagar size at the end of Hagar size 11 at the end of the PSERP. 23 patients never needed further dilations because during the follow-up, the size of the Hagar remained unchanged. The other 10 during the weekly calibration reduced the size of the Hagar, and therefore they started on routine postoperative dilations. With a follow-up period of 23 months, we had a stricture rate of 3% and 12% of prolapse rate. With regard to our results, we think there are a subgroup of patients who still need to be dilated, but we cannot anticipate that in advance. They have to be followed weekly in order to identify the stricture and treat it. To conclude, we can say that there are multiple factors that could determine the size of the anoplasty in the postoperative period after PSERP, and some of these factors cannot be measured. The evidence suggests that not every patient would need to be dilated after a PSERP, but still some of them will. However, there is strong evidence supporting a high level of stress on caregivers and patients when performing and receiving dilations, and further research is required to better understand what the process of healing after PSERP is in order to improve postoperative dilations. Thank you very much. I have concluded my part of the presentation. We can continue with the last question. So, after what you have heard from us today about dilations, do you consider to continue with dilations after you perform a PSERP or a laparoscopic assisted anorectoplasty in a patient with an anorectal malformation? Yes, no, or I have never performed dilations and will also in future not perform dilations.
To wait a couple of more seconds to let more people vote. And around 50% of the attendees have voted, and I'm going to close it now and show you the results. I would like to invite the three of you to come for the discussion, put your webcam on, and we can see if we have some questions from the attendees. So feel free to type in your questions and I can pass them on once they are here.
Thank you very much for the beautiful overview and the in-depth analysis and the practical proposal of an alternative. Thank you both speakers. I think the first thing we should do is comment on the results of the poll, the second question now. It's quite a beautiful result, isn't it? 80% think of changing their routine because of what you presented, so you can be proud of it. And do you want to comment on the details, on the results in detail, Eva and Alejandra?
I'm not able to see the poll. So
you didn't see it. I'm sorry.
Oh, thank you. Well, I'm proud. Thank you very much. As I mentioned earlier, I think there is no perfect protocol for every patient. Taking into account the burden of performing dilation for caregivers and patients, we have to select the patients that need the dilation, but there are some others that they don't need dilation. So why to perform an extra intervention if they don't need it? So I think we need to be aware that some of them will need to be dilated, but some of them not. So I think the main point here is to check them regularly just to see whether the size of the anus was smaller or not?
Thank you very much. We have some interesting questions and comments. The first one is from Professor Jenetsky, who already was quoted. He's a professor of medical statistics, informatics, and he's a board member of the German patient organization SOMA for ARM patients, Hirschsprung and vesico-intestinal fissure patients. And he comments that the study of Ahmad, the prospective randomized trial, also was underpowered and had a highly relevant difference between the two groups as the one from Temple. And he asks a question, why the same size of a Hegar should not be used longer than a week in the postoperative dilation. Do you know the reason, Eva or Alejandra?
Again, the protocol that we all follow is not scientifically proven. So I think we are taking for granted that this is the right thing to do because it's the way we have been taught. But I don't think there is a scientific answer to say not more than 1 week with the same Hegar dilator. And the same way, I don't think there is a scientific answer for performing one Hegar size by 1 week or not, or doing the dilation twice a day instead of once a day. I don't think there is any evidence behind what we have been doing for many, many years.
Mm-hmm. Thank you very much. Professor Jenetsky also comments that he thinks that the sizes of Professor Peña are much too high and very theoretically. Okay, the next question is from Pim Slots, pediatric surgeon from Rotterdam. He asks, do you use steroids to soften the scar tissue? We don't. In tracheas, yes. In neoanus, not.
I don't use corticoids either.
A comment from Miroslava Funakova. According to her practice, it is better to use soft Hegar dilators made of silicone or classic ones to avoid pain during dilations. She asks, excuse me, she asked whether what is to be preferred, the silicone soft Hegar dilators or the classic ones? Eva, you said you prefer the silicone stuff, isn't it? Eva, I can't hear you.
Yes, I think you can hear me now. Sorry, the buttons obviously don't work. Thank you for the question. Well, we have good, we actually have the same results with the silicone dilators as when we use the metal Hegar dilators. And to our experience, the silicone dilators are, there are more, let's say, more, the parents don't hesitate to use them, let's say this way. They think it's an easy instrument. It's not like you basically cannot injure the patient by using a silicone dilator since it's flexible. And that's why they probably are more compliant to use them. And in that way, we really see good results. The only thing what we have to make sure is that silicone dilators are inserted the way we want it, because since it's having a conic shape, you can basically rush through it and go to a bigger size that maybe is not even needed yet. And here we have to really make sure that the correct size of the Hegar dilators are applied, and we have to teach the parents how to use them and do it properly the way we want it. to not end up in a bad result. But we have a good experience, and I also would recommend it using it instead of vasodilators.
Thank you very much. In between, I have to apologize that you cannot see us. We somehow dialed in the wrong way, and now our cameras can't be activated. I'm so sorry for it. Please forgive. The next question, very interesting. Julia Disnan writes, she's a psychologist in a pediatric surgery unit and asks, do surgeons ask to parents if they feel they are able or not to perform dilations if needed? Would you consider alternative procedure, weekly dilatation in clinic, for instance, and or provide psychological care?
I could answer it from my point of view. Yes, we ask the parents if they feel comfortable in doing it. And I think it's somehow a point where we have to make them feel comfortable. It's our responsibility as surgeons that parents have this feeling they can do it. And if they're really reluctant doing it or say they cannot do it at all, then I would always consider weekly, let's say, calibrations and maybe even dilations, in certain cases doing it in sedation, for example. But we rarely ever have to do that.
Thank you very much. By the way, if you don't want me to mention your name, you can ask your questions anonymously. Then you simply put the first word anonymously, and then I will not read out your name. Another question from Pim Sloot from Rotterdam. I stopped dilatations at age of 1 year. Do you agree? What do you think about this? An age limit?
I totally agree. I think performing dilations in older patients, 1, 2 years, is painful and is traumatizing for the patients and the families. So I only perform dilations in the first 12 months after when we perform a PSARP, and most of them underwent surgery before the age of 1. But I completely agree. I think this is very traumatic for an older child.
I would like to comment on this too. We have to differentiate between pain and psychological burden, because when the children get older, you know, all this Oedipus stuff, I'm a surgeon, not a psychologist, but it becomes increasingly traumatic for them to have something done to their pelvic floor, which they do not agree on. But pain is not acceptable even in infants, only because they are weaker and can't fight off. It's not a reason that we can inflict pain on them. So we have to differentiate. Pain never, and psychological problems increasingly with increasing age.
I agree.
The next question from Hans Mengistab, excuse me if I pronounced it wrong. Do you think that primary PSARP and staged PSARP with the colostomy should be followed the same on anal dilation? Very interesting question. What would you say?
I think that the passage of stools through the neo-anus will definitely help to prevent a stricture. I personally follow them the same way once a week, but I agree that it's less likely to have a stricture when the patient doesn't have a colostomy. And usually because these type of malformations are lower types, such as rectoperineal or rectovestibular fistulas. But answering to your question, yes, I follow them with the same protocol, but taking into account that the rate of the risk of a stricture is less in patients with no colostomy, because the pass of the stools act as a natural dilator, I think.
We discussed this beforehand, and Yes, we have the same point of view that the feces might dilate mildly, but in fact, in literature, I found several times the notion that the colostomy protects the anoplasty while it heals, so the stricture is less. There's less risk of a stricture in the patient with the colostomy because the healing is not disturbed. So there is no research on it, and everybody can believe whatever he or she wants.
That's why one of the reasons I try to close the colostomy early in the postoperative periods from 6 to 8 weeks. If everything is healed nicely, I close the colostomy because I don't have to perform further calibrations, because the feces will do dilations instead of checking the anoplasty every single week. So that's why I close the colostomy very early.
Thank you very much. Next question from Mazena Mohideen, chairwoman of SOMA Austria, patient representative. Do parents receive psychological support in the clinics when they have to calibrate their child's anus? Are they offered other options? Many parents fear sedation of their child and therefore carry out the traumatizing procedure.
So I again like to comment on that. I think what Mazena tries to highlight is that when dilations are performed either by parents, of course also by surgeons, the dilation should not be performed in a traumatized way. It should not cause pain to the patients, and when parents are doing it, they should be either carefully instructed and also ask if they feel confident doing it. If they have the feeling it's a huge psychological stress to them or burden, and I hardly cannot do it, then I strongly suggest to include a psychologist to help the parents, but also find other alternatives. Like Alejandra said, check the patients weekly, and maybe that the surgeon takes over the dilation process, or we decide on weekly dilations, maybe even in sedations. But it should be in every way performed in a way that parents are instructed in a very good way about consequences, complications, for example, stricture rates, and just tell them what can happen when we don't do dilations at all, and what are then our next steps.
Thank you very much. An answer back to Pim Slots from Ronnie Sveir. He or she once used mytomycin application, local cytostatic, I think. And he or she also comments on the dilation by the parents with the sentence, 30 years ago, my boss gave the Higa bougies to the parents. It was an awful experience for many parents. So obviously they quitted regular dilations long ago because of parental resistance. Another question, I think, which is in all our hearts, Guillermo Concha, please, which criterion can you use to decide which patient will need or need not anal dilation? So if you again would comment on the criteria to decide when to dilate and when not to dilate.
Sure. I think there are many different protocols, and as we have already mentioned, there is no perfect protocol so far. But the way that we do it in La Paz at my institution, when we calibrate the anus starting 3 weeks after PSARP, if the anus size remained the same as we measured in the operating room, we don't perform any dilation because the anus didn't shrink down. In the contrary, if the patient has a lower size of Hagar, we have to start dilations to try to reach the goal Hagar size. So the decision to dilate or not to dilate a patient will be given by the size of the anus in the postoperative period. We checked it. If the size is okay, we don't do anything. We just calibrate the following week. If the size is smaller, then we start on routine dilations.
I hope this answers the question. If not, Guillermo Concha, please write it again in the chat, in the questions. Cecil Kumara comments again on the question whether the feces will dilate mildly. She writes, I think it is the skin and not the bowel that is the problem here. Skin tends to contract during wound healing, and anoplasty is a wound. If the baby passes solid stools, that will function as a dilator, but during the soft and liquid stool period, the neoanus may have to be kept open. And I think that's very true, because the little babies often have more soft or liquid stools, and we don't want really firm stools which might cause pain or even anastomosis disruptions. So I completely agree with this comment, if I'm allowed to say so.
Me too. Yeah,
I do too. I think once it has been mentioned, mitomycin or like Pim said earlier on, steroids. To be honest, I don't have any experience with both medications in arm procedures. I guess that in patients with a stricture, I like the Heineken-Mikulicz anoplasty. That is an option, what we can do surgically to the patients and help them to achieve again a normal anus size or neoanus size. It would be interesting to maybe even perform studies on mitomycin or steroids, but that probably has to be an approach, yeah, for more hospitals to achieve the patient numbers.
So if anybody of the attendees wants to carry out a study, any protocol against any other protocol, Professor Janecki is very eager to help with very, very professional statistical advice. This is one thing I can offer. And the second thing is, I would like you, Eva or Alejandra, you commented that Mark Levitt routinely sends psychologists to the parents to check whether they will be able to do the calibration by themselves or not. Is this true? Did I get that right?
We talked about it in Pula at the Pediatric Pelvic Reconstruction Congress last year, and that's what he said last year, that he is basically, or they started inquiring if the parents feel comfortable and doing dilations, and if they don't, he tells them that there is the option of a Heineken-Mikulicz plasty if a stricture really occurs. And I don't know if that, I guess that's the consequence after their study, Alejandra, that they saw that, yeah, where they had those two prospective arms of patients where they performed dilations or not. And did I get that right, Alejandra?
Yes, and I think we have to take into account the cultural differences, because when I was in the States, I was surprised by the decision of many families to have a Heineken-Mikulicz if they developed a stricture instead of performing dilations. But here in Madrid, if I offer a family the possibility of not doing dilation with the risk of having an extra procedure in the anus, they will go definitely for dilations. And we comment yesterday about the general anesthesia calibrations and dilations in the UK. This is again a cultural difference, because here in Spain, if I propose families to perform calibration under anesthesia just to prevent pain or trauma, they will say, please, no, I prefer to do the calibration awake because they are so scared about general anesthesia. So that's again why I think there is no perfect protocol for everybody in every single country, because there are so many implications, so many aspects to be taken into account, and cultural differences, is very important in this kind of topics.
Great. Sorry to bump in. I think that's a good comment to end the discussion section of the webinar. It was a very interesting discussion, and I would like to thank everyone that joined the webinar this evening and also participated in the discussion with your questions and comments. A big thank you to you, the presenters, for the interesting presentations. And I would like to take this moment to mention that the webinar has been recorded and will be available on both our GoToWebinar platform and YouTube channel, and I will be sending the links to everyone who registered for the webinar tomorrow. All the links for the previous sessions are also on our website, and you can subscribe to our YouTube channel to find the webinars, the recordings on the playlists. And finally, all of you who have attended today will also receive a survey immediately after the session has finished, and we will be grateful if you could spend a few minutes to fill it in so we can continuously improve further sessions. And with that, I would like to thank you everyone again and close tonight's webinar.
Thank you very much.
Thank you very much.
Bye-bye.
Thank you very much.
Bye-bye. Thank you.
Bye. Thank you.